virtual international SMDC conference under the leadership of worthy principal Professor Zahid Bashir and Professor Khaja Muhammad Azim. The Department of Surgery is offering exciting educational and training opportunities for surgical, allied staff, and students to enhance their continued learning underneath the banner of Shalamar Surgical Symposium. This time, we have around dozen sessions, around 55 international and national experts who will be sharing up-to-date surgical advances and valuable experience in various disciplines. Come and join us for the virtual symposium. Welcome to Shalamar Medical and Dental College International Conference, virtual international SMDC conference under the leadership of worthy principal Professor Zahid Bashir and Professor Khaja Muhammad Azim. The Department of Surgery is offering exciting educational and training opportunities for surgical, allied staff, and students to enhance their continued learning underneath the banner of Shalamar Surgical Symposium. This time, we have around dozen sessions, around 55 international and national experts who will be sharing up-to-date surgical advances and valuable experience in various disciplines. Come and join us for the virtual symposium. Welcome to Shalamar Medical and Dental College International Conference, virtual international SMDC conference under the leadership of worthy principal Professor Zahid Bashir and Professor Khaja Muhammad Azim. The Department of Surgery is offering exciting educational and training opportunities for surgical, allied staff, and students to enhance their continued learning underneath the banner of Shalamar Surgical Symposium. This time, we have around dozen sessions, around 55 international and national experts who will be sharing up-to-date surgical advances and valuable experience in various disciplines. Come and join us for the virtual symposium.
Bismillahirrahmanirrahim. Thank you very much for joining today here in this particular session. It pertains to TEP Inguinal Hernia repair. We have invited Dr. Abul Hasan Kazmi, Syed Abul Hasan Kazmi. He is a master surgeon from Dundee. He is one of the pioneer surgeons in the laparoscopic hernia repair in Ninewells Hospital, Dundee. He has recently retired from there. He was previously a trainer at Shalamar Surgical Symposium Center, Dundee University in laparoscopic surgery, especially laparoscopic gallbladder and inguinal and dissection hernia repairs. He has vast experience in laparoscopic approach, and he has had the privilege of working with Dr. Kushari himself. Today, we have invited him to share a few of the important tips and some pearls of the wisdom for hernia repair. He will be talking about the evolution of hernia surgery, and then finally he will be concluding with some of the tips regarding hernia repair through laparoscopic approach. We have Professor Waris Faruqa. He will be shortly joining us. He is currently working as a professor of surgery at the Sagging Institute of Medical Sciences. He has a vast experience in laparoscopic surgery, including the TEP hernia repair. He will be shortly joining us. There are more people around here as well. Without further ado, we are running short of time, and we will be starting with the presentation. First, I would like to invite Dr. Abul Hasan Kazmi to say a few words before we commence with the actual lecture. Please unmute yourself, Dr. Kazmi.
Sorry. Yeah, hello everybody. Salam from Scotland. I'm Syed Kazmi. I think Talat has said some extraordinary words about me. Well, everybody's learning. I'm still a learner. well, maybe know a bit more about it than some others. What we are going to do today is there will be 4 videos that will be played. They've already been recorded for you. One will be about it's a sort of PowerPoint presentation already recorded. It's going to give you information on the history, the development, and how it is done, the TAP repair and TAP repair. Just to touch on TAP, TAPP. TAP is totally extraperitoneal, and TAPP is transabdominal pre-peritoneal, that you go into the tummy and then come out into the groin and do the procedure and come back. So that's TAPP. So our emphasis will be on TEP, totally extraperitoneal. Anyway, it will all be in the talk. Once we are through that, there are lots of slides. It's going to take about half an hour plus. And then we'll move on. Then we can have a small session of questions, answers, if possible. I'll try to answer. I don't think I'll have answer to everything, but I'll try. Then we will have another one about is a model we have been using in Dundee Kusheri Surgical Skill Center that I devised with the help of the staff over there. So it's only a couple of minutes video. That gives you an idea how we have been training the young doctors here. We have been running courses here in Dundee. I don't know what's happening now because of Corona. The things are at a standstill. Then we will have another video which will be an emphasis on the 3D anatomy, followed by another video which is my joining of my few operations. And this is going to be sort of various procedure. It's about 10-15 minutes video. And then if we have time, I have another video which I will play from my computer, hopefully. That's just a final sort of lesson for everybody. So that's the format. And Talat, if you can kindly start the first one from your end, if it works. Otherwise, I'll start from my end. Thank you very much.
Okay, thank you very much, Dr. Kazmi. We have Professor Tawseef Asghar as well. He has experience in TEP-Hernia surgery repair as well. He will be also part of the panel team. He will be sharing his experience, and he has lots of questions for Dr. Kazmi, I believe. First of all, we will start with the lecture component. It's the cognitive component of the hernia repair. And hopefully this lecture will be suitable for all of the audience. Can you play this one, please? If you have any questions during this period, you can always use the chat box room, and you can share your questions. If you have any quality issues in the voice, you can also share that one as well. Hopefully everything will be well within time, and this whole session is productive for everyone. Thank you, everyone. Let's start with Dr. Kazmi's lecture now.
Hello and Assalamu alaikum from Dundee in Scotland. I am Dr. Kazmi. I've been working in Ninewells Hospital and also in Kusheri Surgical Skills Unit. First of all, thank you, Azim Khwaja and Talat Wasim, for asking me to say something about this laparoscopic repair of the inguinal hernias. And I'm also grateful to Professor Farooqa for helping out in this session. Look forward to seeing you sometime when I come to Pakistan. Now, it says here, a master from Dundee. No, I'm not a master. I'm still learning. We're all learning all our lives. So, yes, it's a humble presentation. So, first of all, I would say that it is going to be consisting of 4 parts. One will be details of the procedure, the concept of anatomy, touch on the history of this development and various complications, how to handle them. And the second part will be about the model we have been using here in Dundee to teach the young doctors in our unit. The third part will give you a concept of 3D anatomy of this area, and the fourth part will be a video of one of my operations that will give you a concept of how it is done. So it's the laparoscopic repair of the inguinal hernia. It's a pre-peritoneal, or I would say extraperitoneal approach. And remember, it is not a new concept. It is a very old concept. We knew about the anatomy for years, for centuries, but the approach is new, obviously. If you go into history, you will see that there was an idea of accessing the common iliac or extraperitoneal approach for the aneurysms, etc. in 1797. That's Abernethy in the UK. Space of Bogros, we know it, that's the extension of the pre-peritoneal space into suprapubic area, and we know the hernias are in that area as well. And then Annandale initiated the anterior pre-peritoneal repair of the groin hernia. That was in 1876. This is the time when the anesthesia was discovered. And in 1920, Cheadle mentioned about the transabdominal posterior approach to occlude the internal ring. And in 1958, Usher in America mentioned about the anterior prosthetic pre-peritoneal repair. So it's not a new concept, it is not a new thing, it's a very old concept. We are only working on those bases laid down by our elders and ancestors. Now this man on the left side is Nihas. He is one of the experts in hernia surgery and a great teacher. He mentioned about the pre-peritoneal approach as well. Then Stoppa is a Frenchman. He also placed a mesh in the pre-peritoneal space by open repair. Midline incision, cleared the space, shoved the mesh in, and come out. Very successful. So our base of the laparoscopic repair is all dependent on all these teachings of the elders. And coming to the procedure itself, 1982, Gare did the first laparoscopic repair. It was in the peritoneum. You go in and you put a stitch in. So, but obviously that failed. Then Deluc in 1991, a Frenchman, did the TEP, totally extraperitoneal repair, 1991. And 1992, Arigui did the TAPP, total, this transabdominal pre-peritoneal repair. You go into the abdomen, make a hole in the groin, and then come out of it, and then carry out the procedure. British Hernia Society has its guidelines along with the NICE. This is the National Institute of Clinical Excellence. It says that TEP and TAP repairs should be offered preferably to the bilateral cases and to the recurrent cases. Expertise should be available. People should be very well trained before they are allowed to do these procedures. And TEP repair can be relatively cheaper. I can show you, and I will show you how it is possible. Open repairs are for the recurrent cases of TEP and TAP, and for small primary inguinal hernias maybe, and for the frail patients and elderly who are not suitable for an operation. And also remember that reusable instruments have been advocated. Those will save a lot of money. And also note that contralateral hernias are 19%. You go anywhere, if you know the route, if you know the way, then it's easy to get to the destination. Similarly, at operations, if we have a good concept of anatomy, then obviously we can carry out the procedure more easily. So same is the case here. Your learning curve is steep, less steep if you know the area. Therefore, it depends what you think. Your concept has to be different. You're looking at things from a different perspective. And it's all in your mind how you get it. We're all used to looking at the anatomy from outside. That's what we've done in our medical schools. That's what we see it all the time. So that anatomy is relatively easy because we see it, we know it, we have been taught that way. And looking at these pictures, say this is a groin, external oblique aponeurosis, inguinal ligament. And if you come here, then you can see this external, ilioinguinal nerve. This ilioinguinal nerve becomes more clear when you open the canal, ilioinguinal nerve, iliohypogastric nerve. If you come here, you can see lateral cutaneous nerve of thigh. I mentioned that because this is the nerve which you need to consider when you're doing the laparoscopic repair. And the genitofemoral nerve. So these are the nerves which you need to take care of even in open operation to avoid any post-operative pain. And that's another further clarification of this. But when you are doing the laparoscopic repair, it's a totally different concept. It is a different approach. It's a different scene inside. Imagine this is the pelvis, and you are sitting at the umbilicus. That's where your camera is. So that's you or me. So you're looking at it. So it's a totally different concept. So I've tried to make certain diaphragms in a sequence to give you a better idea. This is the patient, pelvis. That's you. It means camera. And you're looking down into the pelvis. That's the midline. Pubic symphysis is here. The superior pubic rami are here, and inguinal ligaments are there. And if you look at this further, bladder is in the middle. You have the epigastric vessel, deep inferior epigastric vessels tethered to the back of the rectus muscle. Okay, now you trace them down and they will lead to the external common iliac and external iliac vessels. So this is the area where you have to be extra cautious. And we all know that direct hernia is medial to the epigastrics. Indirect hernia is lateral to the epigastrics through the deep ring. Femoral hernia appears here, and the obturator hernia is here, although it is very rare, just to give you an idea of the anatomy. We have the vas deferens emerging inside from the deep ring, going down into the pelvis, going towards the prostate. Here is the testicular vessels in males, the genitofemoral nerve, and next further away laterally is the lateral cutaneous nerve of thigh. These are important because here you have the triangle of pain. If you mess up in this area, the patient will have chronic post-operative pain, long term. And if you mess up here, you will have the result straight away on the table that you can damage these vessels, triangle of two. That's where the mesh is placed, well covered, all the areas, all the holes, and even across the midline. These are the types of meshes we use. The lightweight mesh and this is the mesh which is the heavyweight mesh. It's all well shaped, but you can use ordinary heavyweight mesh, which should be 15 by 10 centimeter. These are two meshes shown. It says medial M here, which is written on it. Gives you an idea when it is inside that this is the medial side of the mesh. What we tend to do is I started putting these sutures at 4 points to help you manipulate the mesh when it is inside. It helps a lot, especially in the initial stages. Now let's come to think of antibiotics. We don't use antibiotics here. Theaters are really neat and clean. The sterilization is well guaranteed. I would rather spend money on the sterilization than filling the patients with antibiotics. However, it depends on the local circumstances. Coming to the approach, is it with a balloon, without a balloon, and whether you need to tack or fix the mesh or not to fix the mesh. That's how the position is. For the right-sided hernia, the surgeon is there, assistant, anesthetist, and the nurse, and the monitor here. And for the left-sided hernia is reversed. However, we used to have this position. This is very convenient. You don't have to move a lot of things except that the surgeon just swaps if it is a bilateral hernia. So for the right-sided hernia, surgeon is on this side. Left-sided hernia, surgeon is on the patient's right side. Monitor stays here because then everybody can see. Now these are the various steps of the procedure. First, prepare the area. Okay. These are the marks shown for your holes. Umbilicus here, inferior part, that is pubic area. This is for the 10 centimeter incision. That's for the 10 millimeter, 5 millimeter, and 5 millimeter. That's the incision. How it is made is slightly off the midline. We don't want to enter the midline because our aim is to enter the rectus sheath. So this is slightly enlarged after making the incision. These are the small Langenbeck retractors, which can be used to retract the area and to see what you're doing. This is the incision into the anterior rectus sheath, and after doing that, the rectus muscle is retracted laterally. Then you can stick your little finger in and create a bit of space before inserting the camera inside. And this camera goes behind the rectus muscle in front of the posterior rectus sheath, and it dips down over the arcuate line to look down into the pelvis. There are two types of optics we can use, 0 degree and 30 degrees. Personal choice. 30 degree gives you, I feel, it gives you a better sort of approach. You can turn around and see different areas. However, it's a personal choice and experience. We were lucky enough here that we had a chameleon type of optics available. You can manipulate this lens here at the tip to see at 0 degree and up to 90 degrees. Now these are S retractors. They can be used instead of the Langenbecks. They give you a better approach. You can access the holes more easily. However, these are not 100% necessary. The gas pressure is 10 millimeter of mercury. Gas flow, carbon dioxide, is 2 liters per minute. First, I will show you the procedure with the balloon. These are the instruments used in the balloon. These are two simple dissecting forceps. Scissors, hardly used. Keep it handy if you have to. You don't have to really open it. The clip is a disposable. Costs about 100 pounds. So we always kept it handy just in case we have to sort of secure a small bleeder, if any. 5 millimeter 2 ports, 10 millimeter port. This is the balloon for distension of the area, and that's to hold the 10 millimeter port when you're operating. That's how it looks like. And this is the insertion of the first one. To create the space, you inflate with gas, and that's how that's what happens when you are doing when the gas is in. Gas means the air is pumped in. So this is the balloon which creates space inside. That's how it looks like through the balloon. And once that is done, you take it out, you insert the retaining cannula in, and then you fill air into it. It's about 20 ml. That's how it looks like. This is pushed down to create sort of water airtight here. So you can see this. It becomes airtight, so the gas cannot leak. That's the carbon dioxide going in. That's the second port, 5 millimeter down in the midline. That's the third port. After carrying out the procedure, doing clearing all the areas that I'm going to show you later on, this is the mesh being inserted. This mesh is the lightweight mesh going in, further in, and then you see it on the monitor, spread it out. This mesh in the areas to cover. Now, this is another picture added here. These are the heavyweight meshes written here. This is the stitch which I had shown you before. We apply on the mesh. That's another stitch on the other side to help manipulate the mesh. You can see the midline which is overlapping. The two meshes are overlapping in this bilateral case. Once the whole thing is done, you deflate the thing, and then this is the local anesthetic, which is 1% marking. Excuse me, 1% marking that is inserted, that is injected into the space, and following that, the area is closed, sutured with subcuticular vicum, and then covered. Now let's come to the balloonless repair. The balloonless repair, these are the instruments. Simple, straightforward, cheaper. They used to cost us £25 only, so it's much cheaper than the 100 or 200 pound instruments used in the other one. 2 5 millimeters balloons, and you can imagine here there is only one trocar, so that saves money as well. So here is a conical thing that sticks onto that. I'll show you how it is done. This is the 10 millimeter camera. You make an incision, transverse incision. These are two retaining sutures. These are the sutures that they are used to anchor or hold the trocar, 10 millimeter trocar in place, and then once the procedure is done, they simply use to tie it off. And this is the insertion preparation of that 10 millimeter trocar to insert into the area. That's how it is, and this is going in, and that's all in place. So those two anchoring sutures are secured here at these on two sides, so that it is sort of snug fit, so that air doesn't leak or gas doesn't leak. That's how it looks from inside. And if you see here, you'll find now after this procedure, you will find that after dissection is done, after the dissection has been carried out, this is the heavyweight mesh, that's the barred mesh that's being inserted. So you insert the mesh in lengthwise. This is to give you a concept of how things are inside. Indirect hernia, direct hernia, deep epigastric vessels, genital vessels, This is the common ilex ear accessory obturator artery. We read about it. We saw it a couple of times. And this is superior pubic ramus, and the femoral hernia is supposed to be here. This patient doesn't have a femoral hernia. Now, once the mesh is in, you see here this arrow. This arrow gives you an idea. You are aiming the mesh into the left groin or the right groin. So if you push the mesh into that very groin, then life becomes much easier. You don't have to do too much manipulation inside. Once the meshes are all set, these are closed, the wounds are closed and dressed. Now, the benefits. I'm a proponent of the balloonless procedure because I feel that when you're doing the dissection of the pre-peritoneal space, it's all being done under vision. You use the camera end to manipulate to clear the loose areolar tissue. With the balloon, sometimes it has its own mood. It can go into an area where you don't want it to go. And moreover, it may be asymmetrical dissection. If there is a previous operation like appendicectomy, then you end up rupturing the peritoneum over there. But with the balloonless, where you're working on it yourself, then obviously you will have a better control. And obviously balloonless is less expensive. When you're starting the procedure, your sequence should be to start on smaller hernias, and then you move on to the recurrent ones. And you should try to avoid the large inguinoscrotal hernias, incarcerated hernias, and if there's a previous extensive lower abdominal surgery. Also, you should raise the foot end of the table by 20 to 30 degrees because it's just the opposite of gallbladder surgery. Pressure 10 millimeter of mercury. You should make sure that the inferior epigastric vessels remain tethered to the back of the rectus muscle. If they drop, if they sag, they'll make your life difficult. And you should dissect well laterally as well, so the mesh can be placed comfortably. You should do full dissection before inserting the mesh, because once the mesh is in and you find you have not done enough dissection, then it can be difficult. Also, if necessary, you can divide the arcuate line for a better access to the lateral space, but you don't really have to do it all the time. And you should reduce the hernia sac and peritoneum as far cephaloid as possible, at least 5 centimeter space to be created on the posterior wall, because that's where the mesh is going to sit. And do not dissect in the iliac vessels area, because that's when you're asking for trouble. If there's a hole in the peritoneum, then make sure the pressure, gas pressure is reduced. A good communication with the anesthetist will help. Do not split the mesh, because that only creates a sort of weak point. Some people believe in splitting the mesh to accommodate the vas deferens. There's no need to do that. And you should provide instrumental support. I'll show you that in the video. Instrumental support to the inferior edge of the mesh when you're deflating, so that the mesh does not curl up. And you really don't have to tack. Tacker costs an extra 100 pounds. And tacking, you may tack in the wrong place. You may tack into a nerve. So I think I've tacked only one case just to see how it works. Otherwise, there's no need to do that. Complications? Yes, there are dreaded ones as well. Major one is triangle of doom. You mess up with the iliac vessels. Triangle of pain, you mess up with the nerves in the area. Injury to the bladder, injury to the prevesical vessels, pubic space, if you try to mess up in that, enter into that unnecessarily. Pneumoperitoneum can occur if there's a hole in the peritoneum. Small bowel obstruction, if there's a big hole in the peritoneum, the bowel can prolapse through it and it can lead to obstruction. And scrotal emphysema. That's the peritoneal tear. It's a small one, flimsy peritoneum. It was here again. You can manage this with reduction in pressure and all that. So this is what I mentioned: reduce the gas pressure, and if the peritoneum is flimsy, then you can use this peanut, a long dissecting sort of instrument. It has got a cotton bud at the end. It can go through the 5 millimeter port, and you use this for dissection instead of pulling the structures. This is the sagging vessels. They make life difficult. Look at the bleeding here. So the procedure had to be abandoned when all this happened. Scrotal emphysema. Not a serious thing to happen. It's not uncommon as well. You check the patient post-operatively in the ward. If this happens, tell the patient, explain to them, and tell them that it will go away in 24-48 hours. The contraindications to this procedure can be previous lower abdominal surgery. If it's all stuck, you can't get into the space. And the patient can't have a general anesthetic. Obviously, you can't do this procedure on them. Coming to the recurrence rate. Bassini's, we all know, at least people of my age know about it. Bassini's, we have been doing 3% recurrence. This is in good hands. But later on, Liechtenstein repair, Schuldeis repair, Groin hernia systems, TEP and TAP, in good hands after experience, it's about 1%. This is a slide from one of my colleagues in Edinburgh, Steve Nixon. He kindly allowed me to use it. They carried out the audit of 8 surgeons in their department. And they found out that once you've done 1 to 20 procedure, your recurrence rate is 10%. It comes down to something like 2% once you've done 80 plus procedures. The other complication can be a mesh migration. People who fix a mesh, probably it may not happen in those cases, but there are other complications of that. However, these are the records from Royal Infirmary, Edinburgh. They looked at 18 migrations of mesh post-operatively to patients who came with recurrence. There was 13% rolling of mesh upwards, 1% inwards, so no, not 13%, 13 cases out of 18. One was medial migration, one was lateral migration, and 3 were lateral migrations, and something like inferior rolling and downwards rolling. So most of the time the rolling is upwards. It goes up when the peritoneum inflates. It lifts the mesh up and it gets stuck to the interior abdominal wall. It's not doing the job you want it to do. I'll tell you how to avoid that. Other dreaded complication is chronic groin pain, which is relatively more common than people think. This is the primary endpoint in hernia surgery. Overall incidence is 10 to 12%. And this is said to be relatively more common in women, younger people, and patients who have had pain before surgery. And with the mesh, this incidence is relatively less, as far as we understand, because non-mesh repair with sutures and things, there was tension, and in those cases there was more evidence of pain, more chance of catching the nerves and things. However, with a mesh, if you mess up with the nerves in the area, you can still get this problem. Endoscopic repair gives rise to less postoperative pain than the open repair. But again, it depends how it is done. So to conclude, endoscopic surgery is gaining popularity, obviously. And it is better if it is offered to people who have bilateral hernias. Instead of making 2 holes and 1 on each side in the groin, you just make 3 small holes and operate on both sides. And in recurrent cases who have had open repair in the past. And obviously, when you are embarking on this procedure, you must inform the patient fully, discuss with them, explain to them both open and laparoscopic procedures, and also tell them that, look, this is just 3 holes, but inside is extensive, is risky. So patients should know with 3 holes or 4 holes for gallbladder surgery or any other surgery, colonic surgery or whatever, patient may not have an idea that, well, it's a small holes, so there's a small operation. No, it's a big operation. They should realize that. And for anything in life, if you're not getting anywhere, if you're finding your aims are lost, then and you can't put things together, you can't put the jigsaw together, then obviously you need to pause, you think, discuss, and then proceed before you can cause any serious damage to anything. Now, to gain more knowledge about hernia surgery, this is the journal. It is international famed journal. It is available online as well. You can subscribe to it, and you can become a member of the European Hernia Society, British Hernia Society, or there's an American Hernia Society, as well as there is a Southeast Asian Hernia Society.
Thank you very much, Dr. Kazmi. This was a wonderful presentation. We can have some of the questions. There are actually some of the questions within the chat box. I will refer these questions to you. One of the question is how balloon versus no balloon technique is different in terms of quality of dissection and ease.
Yes, thank you very much, Talat. I've been seeing these questions and trying to prepare to answer them. Yes, from audience to Dr. Kazmi, how balloon and no balloon technique is different. The thing is that the aim is the same. With the balloon, it is felt that, as I've shown you in the pictures, it's believed that that makes space for you in that loose areolar tissue, and then you can go into that space. But obviously, once you have put the balloon in and taken it out, and then put the retaining trocar in, you again have to do it. Doesn't do all the work for you. So it gives you, I feel, it gives you a sense that something an instrument has done a job for you. But probably if you don't use balloon, is, as I say, that is cheaper, much cheaper, and you still have to go and do the dissection. So balloon versus no balloon technique, how are they different? I don't think there's any difference in quality. It depends on your experience, how you are trained, and how you are keen to spend money. In our NHS, we are very keen to save as much as possible because that's our money. So that's the way we do. And yes, I mean, just like doing open hernia, I do an open hernia using just 3 sets of stitches, and there are some colleagues who can spend 10 sets of stitches. So that's my feeling. I think balloonless is as good as the balloon technique. It just depends on your approach. Okay, next question. Is that okay? Hope I satisfied this.
Yes, this is one answer. And the second question is by Dr. Tosif Asghar, and he is asking, what is the difference between heavy and light mesh in terms of material quality?
Yes, that's right. Material is the same. Material is the same. But the thing is the space in between the fibers. The fibers in the lightweight mesh are thinner. The lightweight mesh is 60 gram per square meter, just like paper. You have the paper quality, 60 gram paper, 80 gram paper, 100 gram paper. 100 gram is 100 gram per square meter. So this mesh is, say, 60 gram per square meter is a lightweight mesh. So this lightweight mesh, small bit, 15 by 10 centimeter. So it's the smaller fibers as well as the bigger pores in it. Our aim is to let the tissues work around it and make a sort of proper sheet afterwards by fibrosis or those fibroblast approach. So yeah, it's
How is it different in terms of recurrence rates and the quality of repair post-operatively?
I would be very skeptical putting the lightweight mesh on a big hole because it will get pushed, and I've seen it getting pushed. Okay, I will put a heavyweight mesh onto that, and if the hole is really big, then I'll probably tag that as well, taking care of those big vessels and the nerve sitting, which I mentioned earlier. So that's the thing. I think heavyweight mesh for bigger holes,
Do you
lightweight
tag
mesh for
all of
most
the
of them.
time? Sir, do you tag all of the time or selectively in some of the
I
cases?
think out of my so many cases, I've tagged only once or twice. Okay. Yes, there are some colleagues who are very keen on tagging one tag onto this pubic bone and then one superior, one inferior, blah blah blah. And I've seen some videos as well, tagged all over, as if they are carpenters. I think I think if you can get away with tagging if you are spreading the mesh well, you are making sure it's not curling up when you see the deflation being done when you get the gas out. So if you make sure the mesh sits there and you use the proper size of mesh and the type of mesh, then I think there should be no need of that. No
There is
tagging.
another question by Dr. Irshad Hussain, and he's asking, how do you deal with the indirect sac and direct sac? Is there any difference between the two and how they are different?
Indirect sag, the thing is that I think in Pakistan, you guys have experience of very big hernias. Over here, if you get a hernia which is just extending into the top of the scrotum, people, oh, it's a huge hernia, and I laugh at them. Okay, I've seen a hernia in Nigeria which was down to the knee joint. I have a picture of that. People didn't believe me when I told them, no, 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 you're wrong. Well, I might be wrong, but that's what it is. So I don't think that we'll be doing that hernia laparoscopically or a huge hernia into the scrotum laparoscopically. So in those cases, you dissect the sac up, you pull, it comes up. Okay. And if it's inguinal hernia, and obviously you may not be able to do that laparoscopically. But in that case, what you may have to do is, if you're really good at it, then you can circumcise the sac, leave the lower end as we normally do, and then clip or close the upper end. That's what can manage. But I think that will take very long time to handle. So indirect sac, over here we do smaller sizes. Obviously, our patients come earlier. They get attention earlier. So that's the way. Hope I have managed to answer the question.
Yes, and how do you prevent the injury to the inferior epigastric vessels? Would you share any tips and tricks?
So I think I did mention that in the balloon one, when the balloon goes, if balloon enters in front of the deep inferior epigastric vessel between the muscle and the artery, that it will make it sag. that will make your life difficult. But if you're looking at it, you make sure that those vessels are attached to the back of the muscle. They're well up in the roof area, or ceiling, I would call it. Now, direct sag is relatively much easier. You just pull, and it comes off. I don't think you can injure the deep inferior epigastric vessels by doing it. You just need to keep an eye on it. You should know where it is. It's not happened in my case ever. I don't talk big, never talk big. It can happen anytime. But if you take care of structures, if you know the anatomy, if you know where it is, then you should avoid it.
Okay. One of the medical students has asked a question: how the anatomy of inguinal canal is different from the laparoscopic approach as opposed to the conventional one, open approach?
We don't go into the inguinal canal in the laparoscopic repair. As I showed in the pictures, that we look from above. Okay, we look from the umbilicus. You're looking at the deep ring. You're not looking inside the canal at all.
Okay,
so and you don't do anything in the canal. I mean, see, in the open hernia repair, we put a mesh or whatever, Schuldeis repair, whichever repair we are doing. You are working on the muscles. You just put them together. So in this case, you pull the sac up, shove it up, and then hopefully the peritoneum hasn't opened, and then you put a mesh in and come out. That's it. So you don't look inside the canal when we are doing the procedure, laparoscopically. Okay. I showed you the diagram, the pelvis, the internal ring, and the external ring area, those small circles I showed you. Yeah.
So we will work on the anatomy in subsequent section of this session. It will be more clear for the medical students in the coming minutes. Dr. Abbas and Professor Tosif are here. You guys have anything to share at this point before we move on? Abbas and Dr. Tosif.
Assalamu alaikum. I think it was an excellent talk, and very good points were made regarding the hernia repairs and the techniques. No comments apart from the fact that I hope everyone in Pakistan can eventually take on laparoscopic hernia surgery. There has been a long time since laparoscopic hernia was started in Pakistan, but it's still not a norm. So only a few people are doing it, and occasionally they are doing it. So I don't see people regularly doing laparoscopic hernias, and I think a lot of that has to do with the cost and sterilization techniques, and mostly that. So training also is one part of it, but I think even people who are trained are reluctant to do laparoscopic hernia repairs. So the cost is one of the main issues, and the infections is another issue. So we're still dealing with laparoscopic infections, and we don't have reusable instruments. We can't afford reusable instruments. So reusing the ports, and that causes a lot of infections. So just one question from Dr. Kazmi: that what do you recommend regarding cost reduction for us in Pakistan, or any tips and tricks to reduce infections in hernias for us in Pakistan? Because laparoscopic hernias, if they get infected, it's a nightmare for the patient.
I think if people don't mind me saying, it has to be a collective responsibility. The aim and the niyat to get the things sorted out. The thing is that we have to make sure that our sterilization is perfect. Somebody who is responsible for sterilization does it as if they're doing Hajj, if they want to. So it has to be very honest approach to sterilizing the things and care of the instruments and all that. See, over here, we don't give antibiotics to hernias. If we give, now we don't give any antibiotics to even our lap coolies. If you give an antibiotic, the pharmacist will come and shout at you why you're giving it, and action will be taken why you're giving antibiotics to these patients. So, over there, I know I've worked in Pakistan. I have good taste of it. I'm still in touch with Pakistan. So the thing is that it has, again, I say, it's a collective approach. Surgeons and doctors and the patients and the hospitals and the government, the sterilization people, and the antibiotic company, the pushers who sell their stuff. Okay, and people are very keen to buy this stuff as well. So I don't know whether I've been able to answer the question or not.
Yes, yes, it's perfectly answered.
Yes.
I agree with Dr. Abbas, and all of us are on the same page that in coming days, most of the stuff will be done through laparoscopic or minimal access approach. And this effort is actually in the line of those objectives. So we are trying to promote everything. Dr. Tosif has something to say here.
Yes, Assalamu alaikum. Thank you, Professor Kazmi, for excellent video demonstration
भाई
of
प्रोफेसर काज़मी नहीं हूँ मैं डॉक्टर काज़मी क्यों मरवाते हो अच्छा ओके तौसीफ अच्छा जी साहब
ये था कि
Hello?
to the hernia mesh patients you're doing.
Sorry,
you're not giving also.
Sorry, could you say it again, please?
I'm talking about the sir, I'm asking about the prophylactic antibiotic. Antibiotic prophylaxis. Are you? No.
No, we do not give any, and as I said earlier, we do not give any antibiotics to a hernia patient. If you give it, you are in trouble from the hospital, from the pharmacy. I said we do not give any antibiotics to our lab colleagues. If you give it, you are in big trouble. Why you are giving antibiotics? You have to explain to the hospital why you have done it. So no, no antibiotics.
I think we have to move on now with the second component of this session. This is the second talk which is going to be played now.
And we can have some questions after that if you want. So it depends how you. Hello again. As promised, that's the second part. It's about the TEP model that we have been using in Kusheri Skills Center in Ninewells Hospital. It was in fact prepared by me and the team at the center. I shall tell you how it was made, and how we use it. So that's how it looks like from outside. 3 holes, 10, 5, 5. That's the anterior abdominal wall. It is fixed onto an artificial pelvis, and these are the instruments we provide them. 2 doctors work, one at a time. One helps and the other operates. So that's how we do it. 2 forceps, dissecting forceps, the camera port, and the 2 other ports. And these are the 2 meshes provided to them. So 1 for each doctor. Once it is draped, the ports are in, the camera port and the 2 other ports. And that's how it looks like inside. Some cotton wool is placed in the area, so they are asked to remove this cotton wool, and then the areas are well labeled to delineate the anatomy, to learn the anatomy from inside. And this is how it looks like. The camera port here, the other 2 ports in place, and there's a monitor provided on which they can see. That's the surgeon, and that's the assistant standing next to the person. And the mesh, again, as I mentioned in the main talk, that these are the 4 sutures applied. These are helpful in manipulating the mesh inside. M is written here, so that's obviously the right mesh and then the left mesh. That's how it looks like inside. So the anterior abdominal wall, back of the rectus, the deep inferior epigastric vessels dipping down towards the groin, inguinal ligament somewhere here, this is the one, and these are the external iliac vessels, and you will see the deep ring The indirect hernia appears here, direct hernia appears somewhere there, femoral hernia appears there, okay, and you will see from the internal ring the emerging vas deferens dipping down into the pelvis. Obturator hernia is supposed to be there, just to give an idea, and this is the reflected peritoneum already done for them. Okay, these are the velcro points here to which the mesh is attached. It's only in the model, and the mesh has been inserted. Once it is gone in, the mesh is deployed and spread out. So that's the practice to do in the department. Thank you very much.
That is a wonderful model. I believe this kind of model can be very helpful in our part of the world. Sir, would it be possible to have some sort of copy of that model for us?
What I've done is we have about 20 in the department. And when I came back from Pakistan in 2020, after COVID started, I spoke to my colleague there, Benji Tang, and Benji promised that I could take one of them, which when this corona goes and I go to hospital to see him, I've not seen him for the last 2 years. I've not been to hospital for 2 years. So once I go and see him, I will be able to pick one from them, and then we can make some models in Pakistan on a similar design, if you like. So yeah, this was my aim actually, to try to do it. My aim is to train people as much as possible, because I remember one of my colleagues in Ninewells telling me he was getting old, so he was about to retire. He says that I want to train my juniors to the best possible limits, because when I'm old and I go to them as a patient, when I'm at the receiving end, I want the best from them. So I want to give best to my juniors, because they are the ones who will be treating me. So I believe that we should train everybody without any prejudices, bias of religion, race, or whatever, so that they can train, because they are the ones who are going to treat me. And if I want the best for me, I should give the best to everybody without any greed of money or whatever. I think money should be the last thing in medicine.
I think that would be wonderful if we get the model here in our.
Yes, I will get it. Yeah, that's already my aim, that we should get something, and hopefully we'll get on. We will make some similar ones over there. I can't carry so many because that's quite huge. It fits in a suitcase. So yeah, I'll get one, inshallah.
So should we get to the anatomy of the area?
Yeah, let's get to the third one, which will hopefully clarify the concept. This is the 3D animation from Jack Hempin from Brussels. It shows you the view from the umbilical level. You are looking down from the umbilical area, as you would see through the port. This is the pelvic view, and here you see the common iliac vessels, deep inferior epigastric vessels from above, and from the side it gives you a better understanding of the structures. You can see these are labeled as well, and here is the whitish inguinal ligament and iliac vessels, epigastric vessels arising from it. This is another view to clarify the position of the spermatic cord arising from the scrotum, running through the canal, dipping down into the pelvis via the deep ring and the testicular vessels. From the side, it gives you a better view of the anatomy as well. And again, here you see it is relatively clearer. This is going to show the balloon dissection, the insertion of the first cannula, and then inflation of the balloon, separating the structures, dissecting the area for initial entry. You can see the deep inferior epigastric vessels rising above. The two sacs are isolated, followed by the placement of the mesh at the appropriate site. It shows you the area that is covered. Hello again.
That is wonderful. That pretty much clears everything. I think medical students should be able to know the difference between the anatomy of the inguinal canal and how it differs when we approach from the down bottom. So there is a huge difference in terms of the anatomy. Dr. Kazmi, your take on it?
I think from this video, I went to a center in Belgium and followed by a center in Germany. And then I went to Spain as well during my training times, where I learned all these things, the laparoscopic incision hernia as well. This video I was given kindly by one of the surgeons, Jack Hempin, in Belgium, and he allowed me to use it. So what I did, I edited it to make it small. It's about a half an hour video. So now from this video, one may take the impression that I'm promoting or I'm in favor of the balloon. The thing is, this video was made in the times when the balloon was the only way to do the procedure. The balloonless was afterwards. But again, you see, this balloon is not, in this case, it was ideal. It raised everything up, pushed everything down, and did everything for you. No, it doesn't do everything for you. It just makes a small space in which your camera goes. You have to do the job afterwards to dissect all the areas and crevices and all those corners and things. So don't take the impression that this balloon is great and it's done it. And it costs 200 pounds, a lot of money. I would rather spend only 25 pounds to do the procedure, to the balloonless one, rather than spending 200 pounds of my NHS. So any question on this from anyone?
Is there any cheap alternative for balloon available?
I don't think there's any cheap alternative to balloon. By the way, why, if we get good training on a balloonless procedure, which I did from Edinburgh as well, Steve Nixon, he taught me. There was Pardeep, he taught me. Okay, Kumar was my teacher in Edinburgh. He taught me. So I learned the balloonless, and I underwent the hernia, this operation as well. I went to them, Edinburgh, to do it for me, and I came back next day. So it's great, and I don't think balloonless is a problem. If you learn it well, if you're taught well, then I don't think there should be any problem.
So does the size of hernia influence your approach, balloonless versus no balloon?
No, it won't. The size of, did you say size of the hernia? Size of the hernia will influence whether I should do it open or laparoscopically. It will not change my, it will not affect me whether I should be doing a balloonless or a non-balloon. So size of the huge hernia, no. Don't do it laparoscopically.
What is your cut point for doing it laparoscopically versus open?
It depends on the experience of the person. The more experienced you are, the bigger cases you can do. But I would still say that inguinal hernia probably is a big no-no, right? So, and again, I say, never promise to a patient that I will be able to do this procedure for you laparoscopically 100%. There's no 100% in life. Even God has not given us anything 100%. Professor Kusheri, our boss, our teacher, our father in laparoscopic surgery, he never promised to anyone that your procedure will be 100%. He would convert as well when it comes to difficult things. So do tell the patient there may be conversion.
Okay, so the message is very much clear that the patient selection for laparoscopic approach will be very appropriate, and the patient should have a clear message that if there is a difficulty, we will have to move on with the open approach.
Yes. बंदे को अपना ही पता होना चाहिए कितने पानी में है. Surgeon को अपना पता होना चाहिए कितने पानी में. I know there's a Turkish audience among us as well. So we should know how much we know. Yes.
Sir, Khwaja has something to add here.
Kazmi sahab, आपकी बड़ी मेहरबानी है. I am extremely grateful. What a beautiful and what a informative talk you have given to us. मैं तो यही दुआ करता हूँ कि कुछ हिस्सा आप यहाँ पाकिस्तान में गुजार लें कि लोगों का भला हो जाएगा. आप जाके वहाँ जाके बैठ गए हैं स्कॉटलैंड में, हमें आपका क्या फायदा. यही शाह साहब भी फरमाते थे कि भी काज़मी साहब का फायदा कब हासिल होगा.
मैं वेला बैठा हूँ, ये कोरोना खत्म कर दो, मैं आ जाता हूँ.
अगर आप चंद बंदों को ट्रेन कर दें तो आपको रोज क़यामत की बड़ा फायदा होगा. इंशाल्लाह. मेरी तो यही दुआ है कि अल्लाह ताला आपको तौफीक दे कि आप फ्रीक्वेंटली आए, हम आपका बंदोबस्त करते हैं आने का और आप यहाँ आके पढ़ाएं.
Azim Khwaja, I love you very much. Yes.
Thank you very much. You have given such a precious time and you taught us lots.
अब एक फिल्म है वो, हाँ, अब एक वीडियो चला लेते हैं इसके बाद. तो इसके बाद मेरे पास एक वीडियो है. हाँ.
The video of the procedure now.
ठीक.
Mr. Kazmi from Dundee, Scotland. I'm going to talk about the TEP repair. This is a video from one of our cases. That's how we prepare the patient. These are the instruments which are generally required for this procedure, as I've shown you before. These are the ports required for the balloonless repair, and this shows the instruments and ports required for the balloon repair of the procedure. The procedure going to be shown is the balloonless one, so these are the cheaper instruments, and this is the endoclip 5mm port endoclip that is kept handy in case. Local anesthetic is given, injected to one side of the midline, and the first port is either on the right or left of the midline. Is a transverse one. Two sutures are often kept, 0 PDS and 4 vicryl. After making an incision in the anterior iliac sheath, anterior rectus sheath, 0 PDS 2 stay sutures are applied. These are used for insertion of the camera. The camera goes into an area behind the rectus muscle. That space is created with the finger. And once the port is gone in and the cone is well in place, the anchoring sutures are stuck on the two sides of this. This is the arcuate line. You are seeing everything through. By movement of the camera, one is able to do sufficient dissection of the area. It's a 30-degree camera which is being used here to lose areolar tissue. This is the view from within, which is seen on the screen. Once that port is inserted, the second port is 5mm port is 4 cm above the pubic symphysis, and that's the local anesthetic injected all the way through. It's also a test that you are in the correct place, and once that port is gone, the third port is again 5mm, and that's inserted. So you can see this is local anesthetic for that port, the third port. Once that is through, the third port is in as well. This is the external view of all those ports. Dissection is commenced as the surgeon is standing on the left side. The dissection is in the right groin. It's just a simple separation of the loose areolar tissue, taking care not to use force anywhere. That's the right sac visible. This is being moved up by blunt dissection. No sharp dissection, no scissors. That's the peritoneal reflection. Peanut can be used for a better dissection, especially if the peritoneum is very thin and flimsy, to avoid any opening in the peritoneum. You can see the vas deferens. Testicular vessels and vas deferens curving over the iliac vessels. This white structure on the medial side. Now you can see the pulsating deep inferior epigastric vessels, which are well tethered to the back of the rectus sheath. Right iliac vessels and artery, the vein and artery are visible. Be careful. That's the superior pubic ramus, midline, pubic symphysis. Now the dissection in the left groin, the surgeon stands on the right side of the patient. Again, similar procedure. Again, patience is a virtue. And here you can see the reflection of the peritoneum. Very slow dissection. Good clearance laterally so that the mesh can sit there very comfortably without folding. You can see this again. This is the peritoneal reflection. Again, these are the deep inferior epigastric vessels. Use of endopeanut to dissect the sac further. It's less traumatic if used properly. You can see this vas deferens, the whitish structure curving medially. These are the testicular vessels I'm touching. You see the pulsating Iliac vein, stay away from it, be very careful, again extra careful. Insertion of the mesh, right side, as I've dissected right side later, so right side first. Once this is the lightweight mesh being inserted, this mesh is spread out, lower edge is well tucked below the edge, MC is medial. So once it is there, it's all set, well tucked laterally, superiorly, spread out very well, no curving. Now we assess the right groin, left side is done. The right mesh is in, is well spread out again similarly, laterally, medially. There should be medial overlap as well, as I'll show you. You'll see the lower edges are well tucked below the peritoneal reflection. Now in case of heavyweight mesh, which we have been using, the BARD is a 3D mesh. We apply 4 sutures at 4 points. M means medial. These sutures are used to manipulate the mesh because sometimes it can be difficult while inside. Now as you can see, the stitch is being used to manipulate the mesh. M is medial, this is the left mesh. You can see the mesh curling up. It shouldn't happen, otherwise it will not cover the area, so it's got to be tucked down very well below the peritoneal reflection. So make sure the peritoneum and any fat there is placed above it. Otherwise the whole procedure will be flop. Medial edges are overlapped in the midline. Again, you can see the lower edges are being pushed well below the peritoneal reflection. Once it is done, you infiltrate some local anesthetic into the space, support the lower edges of the bed. Don't grab them, just support them. See how they are being supported. That's the inside view. Deflation being carried out, and here you are. And gently remove both instruments and all the ports. Slowly withdraw. One port out, second port out, and the third port out. Now those stay sutures are being used to tie and close the hole, because now much easier. That's it. Subcuticular forovicral. Patient doesn't have to come back to us or to the GP for removal of sutures. Saves time, saves pain, saves money. Steri strips, patient is advised to remove them in about 8 to 10 days while in the bath. And these are the dressings. Patient can remove them, and that's the team.
Thank you very much, Dr. Kazmi. That was a wonderful video. It was pretty much clear that the anatomy of from the bottom is quite different from the inguinal canal, what we see in an open approach from interior aspect. Would you like to? There is a question from the audience. So, what is the triangle of pain and zone of disaster? Probably the audience are referring to what we should do and what we should not do while doing a dissection in that particular area.
Yes, triangle of pain and triangle of doom. Doom for the patient and then doom for the surgeon as well, because in this country you go to prison. Triangle of pain because see, I mentioned to you those nerves coming down, the ilioingular nerve, iliohypogastric nerve. We see them in the groin, but they come from the back. They come from the back, curve down, and go into the groin. So when you are operating in the back, if you are messing up too much, if you're dissecting too deep, if you're not just working in the loose areolar tissue, and laterally, if you go laterally, there is a lateral cutaneous nerve of thigh, which is this much distance. It runs along the iliac crest. It sits on the iliacus muscle, under the iliacus fascia, and then curves on and then comes down and supply the small area on the lateral part of the thigh, upper part of the thigh. So these are the nerves which if you dissect too much in those areas, the patient may have post-operative pain. And secondly, if you tag, then one of the tags may go into these nerves and disturb them, and this patient will have continuous post-operative pain, and that will be a long-term chronic problem. So that's the pain, triangle of pain. So be careful in that. Triangle of doom is very clear. Doom is death. And if you mess up, you saw those pulsating vessels, artery and nerve, you mess up with one of those, disaster. Okay, you need a vascular surgeon around to help you out. And quick open procedure. The thing is, in our hospital, for every laparoscopic hernia we carried out in our peripheral hospital, which is, we have peripheral hospitals here as well, because Scotland is very, very thinly populated and hospitals are scattered all over. Our main hospital, Ninewells. So whenever I went and operated in a peripheral hospital 23 miles from here, one list every week, whenever I went there, the rule there was that if you're doing a lap chole or lap hernia, you must have at least 2 units of blood available in the fridge in the operation theater, named for that patient. If there's no blood, you won't do the operation. The reason was that if any disaster happens, then you deal with it straight away if you can. As soon as the operation is done, patient go to theater, that blood comes to the blood bank and is used for some other patient. You know, in this country, we don't have to beg for blood, buy blood. We don't buy even body organs here. They're all donations. So that's the way we work. So triangle of doom, external iliac vessels, be very, very careful on that when you're operating in that area. You saw them pulsating, and they're not friendly if you disturb them. So hope it is clear.
Yes, it's very much clear. Khwaja Saab, I have something to say here.
I have only one request to Kazmi, that he should come to Pakistan and have a regular training for our junior people who are going to become laparoscopy surgeon, because laparoscopy is the order of the day. ये मुझे शाह साहब उस वक्त कहा करते थे कि वक्त आएगा कि लेप्रोस्कोपी है वही सर्जन सर्वाइव करेगा, बाकी जो है सर्जन जो है वो
नहीं वो वक्त के साथ साथ चीजें तब्दील होती हैं. Obviously we are evolving. Yeah, I'm watching Usman. I watch Artogrul on TV. I mean, any wound, I think about pneumothorax. and they just wake up, they just burn the wound and stand up and start fighting again. I mean, we don't live in those days, 4, 5 centuries, 6 centuries ago, but this is different century, 21st century, and things are
Yes,
going to change. I mean,
absolutely.
we have moved on, and obviously, and some people, the modern surgeons, they sometimes think to believe that the old ones are crap. No, they're not crap. Whatever we do today is based on their experience and their teachings. Once it's just we're going off a little bit. Once I told a nurse that, you know how they used to diagnose diabetes? She said, how? I said, they used to pour urine on the floor and wait for the ants to come. And she said, what a crap. I said, no, this is not crap, because in those days they didn't have those sticks to check the urine, blood sugar levels. They didn't have these tests available. So obviously, those are great. The Jali Noos and the Hayyan and all those people, the Arazis and Qasim, and all these guys, respect them. Our salute to them, because they are the ones who taught us every day. Aristotle, okay? So yes, salute to them. Everything we do today, we owe them. They're our fathers.
Yes.
So everything is based on what has been done previously. What are the important don'ts in this procedure, sir?
Important don'ts.
What should not be done?
Okay, I'll show you that video, and then we can talk about don't.
Okay.
Yeah, that's a don't. That's a don't video actually.
Okay.
Video. Yes.
Okay, I'll share screen, and I hope I'll be able to play that. I've got 2 screens in front of me. Let me see if I can bring it down. Shall I share screen first?
Yes, please.
It's asking me to share this screen. Oops. You can see my family. It will just come. I hope it comes. Yeah. Okay. Just watch it.
To the right side, throws downfield, wide open. Jason Claremont, 20-yard line, to the 10, 5, touchdown, DC.
Dickinson and Claremont. This combination is going to be big all season long.
Whoa! Look out! Whoa! What the heck is going on in here?
But we do understand that it's very important to be patient.
Yes. So that's the stop sharing. We'll go to there. Yeah. Okay. Yeah, that's the lesson. That's the lesson of the day for everything in life. What happens is that, first, as Khwaja Azim said, never put any time on any operation. Never overestimate your abilities, and never underestimate the patient. Okay, and as far as time, don't say that I'll finish this operation in half an hour. I can do lap chole in 20 minutes. Rubbish, total nonsense. Take your time. And most of the time what happens is operation has taken a long time. You're coming towards the end of it. You're tired. Maybe you're hungry. Maybe you have to go somewhere after that. The gallbladder is about to be pulled out. Oh, forget about the bag. I'll do it without bag. And you spill all the stones in the peritoneal cavity. You have to remove them. You can't just leave them there because they're the nidus for infection. So it's at the end, things always get destroyed. The problems start. So never rush, never rush, never rush. So that's the take-home message in anything, even when you're reaching destination. Lots of those shipwrecks, they don't occur in the deep seas. They take place near the ports as they're approaching, because that's the time when people tend to say, okay, now we are home. Lots of accidents take place at home. As soon as you're getting out of house, you're reckless. You're about to approach home, you're reaching home, you say, oh, I'm home now. That's where you bump into something, even your own boundary wall. So, yeah.
Any other tips and tricks that you would like to share? Any other important things that a young resident or a surgeon should critically have in his mind before starting this procedure?
I think that applies to every procedure, and it applies more so to the laparoscopic procedures, because the learning curve is very, very steep. It takes longer time. You have to do more procedures to learn them. Have a good idea of anatomy, which is very important. You know your path, your track, and don't just say, I've done a course, I'm going to do this procedure now, full stop. No, do the course. Maybe do a few operations under supervision, and after that, then you proceed to next steps and next steps and next steps. So never take chances. Professor Zafar used to say, don't take chances on anyone's life. If you want to take chances on your life, go and jump off the cliff. That's your life. You deal with it yourself. So it's human life. It's people's relatives. There are emotions. There are people. There are relationships. There are issues. These are families. So look after them. Respect them.
So this message
deal with them the way you want yourself to be dealt with. And that's the humility a surgeon should have. Full stop.
This message is shared by all of the surgical community, and
yes, I know some surgeons. I won't name anyone. Did a course, started doing lap coolies. Terrible complications. One of them even called me and asked me, what do I do? I said, send it to Lahore immediately. I know somebody was talking about the injuries to the common bile ducts and all that. Yeah, send it to those people, because they're the ones who can deal with it now. But don't just, you've just done a course and you've started doing the operations yourself away from the centers and all that. That's not fair. It's very unfair to patients. Very unfair. And never claim that I will do this procedure 100%. Tell them the complications and problems. I know of a surgeon who promised to a patient that I will, it's not here, not in this country. You won't survive. You'll be in the prison if you do that. That I will do this procedure 100% laparoscopically. And you know, at 12 o'clock at night, who the hell are you doing this operation at? Why are you doing this operation at the midnight? You're probably working in a government hospital during the day, and now you're working in a private hospital in the middle of night. And he called another surgeon, can you please, for God's sake, come and help me because I'm stuck. And I promised to this patient that this gallbladder will come out laparoscopically and I will not open it. And they had this other surgeon had to go and rescue this man. No, never do that. Never do that. Never claim.
Absolutely, we agree with it. And the ethics of surgery should be maintained by all of the personnel. And there is no alternative to proper training. And without proper training, none should attempt any sort of procedure, let alone laparoscopic surgical procedures. Dr. Tosif, do you have something to share here at this juncture? Dr. Tosif, are you around, Dr. Tosif?
Dr. Tausif is muted.
He's probably muted.
Yes, I'm here.
There is one question, Dr. Kazmi, what is your experience with laparoscopic varicocele ligation?
Nothing. I've never done it. I'm a general surgeon. In our place, this goes in the domain of the urologists. So no idea.
One of the participants had said the ethics are required in Pakistan. You agree? Everybody agrees. We have to maintain this notion in our practice, and we need a conviction to implement in our lives as a surgeon as well. Anybody else would like to share anything?
I want to say one word. Kazmi Saab is very important for the surgeon. He should be professionally and financially honest.
No, everyone should be financially honest. The thing is, this lecture is now becoming more of a moral lessons thing. We talk about Hippocratic oath, but on top of that, we have another oath. That's our prophet, our father. Okay, so whatever Quran has told us. So why don't we follow that? There's no point in saying namaz 5 times a day. Sorry, it's becoming a preaching lesson now. There's no point in saying 5 times namaz and roza and all that when you're not even caring about. I know there are lots of people in Pakistan who are working very hard. They're very, very honest. And as Hamid Ali Shah, my teacher, Hazim Khwaja's teacher, used to say, "ए मुल्क जिहड़ा ने तेरे 2-4 गधे मिलके चला रहे ने, इस वास्ते चली जा रहे, otherwise it बर्बाद हो जाना." There are lots of honest people over there who are still running the country. That's why the country is running. Otherwise, it's a write-off. Yes. Sorry, we end up going into politics now.
Let's put some good things here and a message of hope that things will improve over a period of time and good people will keep on working for the good. And all of the surgical community should commit themselves to one and that is the surgical ethics. Thank you very much, Dr. Kazmi.
I would say one thing that we inshallah let this COVID settle. I already had a plan. As I said, that I'm going to acquire a model or 2 from here. We can make some and start something in Shalamar. Azim Khwaja is there, you are there, and Tausif is there. So so that will be very nice. And then we can train people as much as we can, and do something for our own people. Yes, I'm free. I'm retired, so I have no problem.
I think it is also the moral duty of fellow of Royal Colleges, fellow of these physicians and surgeons in Pakistan. I think that is their duty to call them the experienced people from outside, because what I am seeing is there is no influx. There's an efflux from here to outside, and influx is momentarily it's stopped. I don't know. That is why the level of education is going down. That is the thing which is worried me.
कुछ ना फरोल ये यहाँ पर जलते हैं बात करते हुए, रहने दें, छोड़ें। हाँ हमारे जफर अहमद साहब भी एनिमीज बनाते रहे अपनी दुनिया में बोल के, उन तुसी भी वही करोगे, रहने दो बस, ठीक है। PMDC का बॉस 5 बिलियन का गबन वो फिर गया, कुछ नहीं हुआ, चलो छोड़ो कुछ नहीं. We should do things at our level. Yes, we should do at our own level. I think there are good people around, and hopefully coming years things will improve, inshallah. And if audience have any questions, they can post the questions in the chat room, or we will be concluding our sessions. So yes, it's a pleasure, and we should stay in touch. If anyone wants to get in touch with me, I'm sure Talat can, somebody can help out. feel free. So we should keep communication open. And Talat, thank you very much. So nice of you. It's always a pleasure communicating with you. Yes.
Dr. Kazmi, thank you very much for taking out your time and taking a lot of effort in preparing this talk. And we are very thankful and obliged. And it will be our pleasure to host you as a trainer at Shalamar Hospital. In coming years, when the COVID is over, you please join us and teach us and our residents about laparoscopic approaches to hernia repairs and other
And
stuff.
I will talk to the higher authorities. Talat, I will talk to the higher authorities about this one because there should be a proper training of laparoscopy. This is not the way that you do one operation and hurt 10 patients. No. It should be proper training, and it should be training from a proper trained laparoscopy surgeon. Unfortunately, there is no proper training center for laparoscopy. They're all self-made. No supervisor, nothing of that there. मैंने बात की थी वहाँ एक हेल्थ सेक्रेटरी के साथ कि जी जहाँ पर कोई सीट है जो प्रॉपर हायर सर्जिकल ट्रेनिंग जो है लेप्रोस्कोपी में के लिए उन्होंने कहा यहाँ है ही कोई नहीं, यहाँ सारे जो हैं वो सेल्फ ट्रेनिंग हैं, अपना करते हैं जनरल सर्जन और साथ लिख देते हैं लेप्रोस्कोपिक सर्जरी. They are total two different domain. You see people now in the United States, there are certain hospitals which are only doing laparoscopy. The biggest center in the United States. Some they are doing laparoscopy, some they are doing robotic surgery. There are different types of sections there. But इस कंट्री में ये है कि ये खिचड़ी पकी हुई है, हर बंदा जो है हर काम कर लेता है, चाहे उसको आता है या नहीं आता. मैं फिर बार बार इसलिए कहता हूँ कि ये बेड़ा गर्क हो गया इस अदारे का. इन्होंने मजाक बना दिया है सर्जिकल अप्रेंटिसशिप को. मैं मजाक नहीं करता कालिम साहब, आप जिस दौर में गए थे वो बहुत अच्छा दौर था. अब उससे बहुत ही झूठ पे बना है. प्रोफेशनली, मोरली एंड फाइनेंशियली डिसऑनेस्ट.
हाँ तो वो तो खैर हमारे ऊपर भी गया हुआ. छोड़े खाचा साहब अभी.
कल से दुख तो होता है ना, काम ये है कि इतने आला बंदे बाहर बैठे हुए हैं जो कि आके ट्रेन कर सकते हैं, उनके लिए रास्ता ही कोई नहीं है. जो बंदे 12-12 साल कार्डियोलॉजी में काम करके आए हैं वो अक्रॉस द रोड बैठे हुए हैं. दे हैव नॉट टेकन इन देयर अपना मेडिकल कॉलेज, अपने पेरेंट्स मेडिकल इंस्टीट्यूशन में उनके लिए कोई जगह नहीं है. जो कि बाहर से प्रॉपर ट्रेंड होके आए हैं, ग्रेट ब्रिटेन से, यूएसए से, उनके लिए कोई जगह नहीं है. दे आर सिटिंग अक्रॉस द रोड. तो फिर आप कहते हैं कि जी एजुकेशन जो है वो बड़ी ऊपर चले जाएगी. कैसे चले जाएगी जब बंदे नलायक हैं पब्लिक हॉस्पिटल के अंदर जिनको कख नहीं आता, और वो जो है आप उनके वहाँ हेड बना नहीं. सब इंडिया में था, आपको याद होगा कि इंडिया में जो काबिल लोग थे वो बाहर आ गए थे, जो चाहत थे वो उनके इंस्टीट्यूशन में है. अमेरिका में भी वो वहां से MD MS करके आते हैं, उनको कुछ नहीं आता इंडिया से. तो यही हाल हमारा हो गया. FCPS सीनियर रजिस्ट्रार वाला खाना को नहीं आता, वो कहता है जी मुझे असिस्टेंट प्रोफेसर बना दो. ये आप काजिम साहब यहाँ हालत होगी. आप आएंगे जब आप उनके साथ डील करेंगे तो फिर पता चलेगा आपको कि हम कितने लेट डाउन हो गए, हम पीछे जा रहे हैं.
नहीं वो 3 साल रह के अंदाजा हो गया था मुझे 91 से 95. आपने
तो इस चीज को गुजरे हैं. आप मुझे शाह साहब कहते थे कि काजी साहब के लिए ये मुल्क है ही नहीं. मैं क्या आप ठीक कहते हैं. आपने तो यहाँ आकर रहने की ट्राई की थी आपने इन गुड ओल्ड डेज में, मुझे याद अच्छी तरह. तो अल्लाह ताला ने आपको बहुत थैंक यू वेरी मच. यू हैव गिवन लॉट ऑफ टाइम टू अस. आई प्रे फॉर यू कि अल्लाह ताला आपको ये तौफीक दे कि आप अपना ये इल्म दूसरों को बांटते रहें. पाकिस्तान में आए, हमारी कोई इतनी पावर तो नहीं है, लेकिन बाहर जहां तक हो सकेगा हम जरूर कहेंगे ताकि बच्चों की ट्रेनिंग हो जाए. आई शुड कीप माई सेल्फ द प्लेस वेयर यू कीप द पेशेंट्स. कि मरीज को आपको उसी तरह ट्रीट करना चाहिए अगर आप मरीज हो कि आपके साथ क्या हो. सिंपल एज दैट. बिल्कुल. डील विद द पीपल. मैं मरीज मैं लेटा हूं, मेरे साथ क्या होना चाहिए. बिल्कुल. और इसी मरीज के साथ वेरी हेल्पफुल. दैट इज वेरी सिंपल. कोई जरूरत नहीं है अखलाकियत बयान करने की. ये जस्टिस सरदार मोहम्मद इकबाल ने मुझे एक लफ्ज कहा था, ही वाज चीफ जस्टिस ऑफ हाई कोर्ट. उन्होंने कहा ख्वाजा साहब एक बड़ी सिंपल सी चीज है, जब तुम बिस्तर पे लेटे होगे तुम्हारे साथ क्या सलूक होना चाहिए, वही इसके साथ सलूक कर दे. वही इसके साथ. बिल्कुल. एज सिंपल एज एनी प्लेस. ये तो हदीस भी है. ये तो हदीस भी है. हुजूर पाक सल्लल्लाहु अलैहि वसल्लम का फरमान है.
So let us conclude this session now by one word, that hope will remain and good will remain and sustain till the doomsday.
Yes.
So let's hope for the best. And we
keep the finger crossed.
Kazmi for everything that he's done for this session to be practically casted here. Thank you all participants for your kind participation and your contribution to this session. And if you have any feedback, you can fill the feedback forms. And if you like to contact us, you can contact us on the email address that is tvasim@gmail.com, or you can contact our Department of Surgery PA, Mr. Vakas. His email address is q.vakas42@gmail.com. I would like to thank all, and I will conclude this session now. Thank you very much, everybody. Hope everyone stays out of trouble in terms of COVID-19. Goodbye, everybody. Thank you very much. Assalamu alaikum.